So this, as Tom was saying, this is a talk that actually I give annually to our first year residents, and I've been doing this for several years. But given the circumstances with the global, awakening to issues of systemic racism, um, with the brutal deaths of, Breonna Taylor and George Floyd, now we're dealing, of course, with the shooting of Jacob Blake. A lot of you have expressed your sincere desire to increase your understanding around these issues. So Tom and I thought this year it might be appropriate for me to move this into sort of our lunchtime health equity series. So I'm thrilled that you can all join us today. For the first year residents, we're going to continue our workshop for the rest of the afternoon. But this is sort of the lecture portion. So I'm hoping that what we'll do here is have really think about what we are confronting as a Department of Family Medicine and Community Health. I'm hoping that as you see a lot of these slides go by, you will sort of challenge yourself to think about, how are we individually as well as how are we institutionally perhaps complicit in the status quo? And then I'll give you a sort of a little glimpse into opportunities as we embark upon this long road ahead, trying to become an anti-racist department, and give you sort of a smattering of some tools that we could start thinking about. I also wanted to especially thank the UW Health leadership for allowing our clinics to participate in this talk as well. So particularly to Alicia Rizzo, who helped make that happen. So thanks for all of you who are able to join us. So the objectives I have are, we're going to be reviewing the current landscape of racial and ethnic health disparities. We're going to consider the impacts of social determinants of health, including racism, upon health, and consider strategies to move toward health equity. So, we are all well aware that health disparities plague the United States, and I wanted just to call your attention to this book. So some of you have seen this slide before that I've shown. This book is called Unequal Treatment. It was commissioned by Congress and published in 2002 by the Institute of Medicine. And here, the members of the committee at the time reviewed over 100 studies across the nation, looking at issues around race and ethnicity and health outcomes. And what they found was that racial and ethnic minorities receive lower quality healthcare than non-minorities. And this is even when income, insurance status, and medical conditions are similar. And examples that come out of this include that African Americans were found to have 4 times the likelihood of having end-stage renal disease, yet only 70% as likely as whites to receive renal transplantation. Latinos with fractures were 2 times less likely to receive pain medications than whites. And in fact, Asian Americans have lower rates of colorectal and breast cancer screening than whites. We have been tracking these health disparities for decades. And so it was actually under Ronald Reagan administration, his administration, that Margaret Heckler started the Black and Minority Health Report. And so we report on these disparities every year, and this is still what it looks like. So this is infant mortality rates by race and ethnicity. And you can again see that African Americans and American Indians have a significantly higher rate of infant mortality compared to whites. Of course, we are looking at this around issues of COVID-19. And again, looking at mortality rates, you can see here again that African Americans have significantly higher mortality from COVID-19 compared to whites. And then you could say, well, maybe it was really inappropriate to give those African Americans that transplant. Or you might say perhaps those Latinos really didn't want those pain medicines for their long bone fractures, right? I'm being a little facetious here, but there was a study done which looked at true clinical appropriateness and patient preference. And even when you looked and took that into account, that only accounted for a fraction of the disparities. And really, disparities are mostly driven by the operation of healthcare systems, the legal and regulatory climate, as well as issues of frank discrimination, both institutional and probably individual as well. And so while there's certainly a moral argument for health equity, there is certainly an economic argument that we could make as well. So you could think about our changing demographics as something important to consider. So some of you are aware that the US Census is predicting that the United States will be minority white by 2043. And think about this. If the majority of our workforce is on the wrong end of the disparities equation, we will not be a productive nation. You should know, though, that actually, if you look at public schooling across the land, public schools across the United States are already majority minority. In other words, already majority children of color, and that change occurred already in 2014. So if you are originally from the state of Illinois, for example, Illinois as a public school state system is majority minority. What about Madison? So when I moved here in 2010, this is what I was told. I'm moving to a white liberal town. And this was Madison Metropolitan School District in 1994. So it was something like 76% white. But this is what it is in 2019. So you should know that here in Madison, we are already majority minority for children of schooling, children of color in our public school system. And when I showed this to our department back in 2014, many people were surprised. I showed this slide to the Department of Surgery in January. Many people were surprised. So you should be aware about this. And then for the residents, just you can see here at your different clinic sites, this is the change in percent whites in public schools in Baraboo, Belleville, Madison, and Verona, as well as Wisconsin as a state overall. So demographics continue to be shifting. And many people think that when I'm giving talks around racial and ethnic health disparities that I'm focusing on an urban population, but you should know that this has a profound effect as we move into the rural population as well. So you can see that if you're African American and you're African American living in rural America, your mortality or your life expectancy is far worse than if you were white. If you actually look carefully at the slide, you'll see some interesting results around Hispanics. So that's called the Hispanic or Latino epidemiologic paradox. And there's a lot of studies trying to understand what that means. So we won't get into that, but I just wanted to point that out. So what is really driving health outcomes? Some of you should be familiar with this graphic. So this comes from county health rankings from our own Population Health Institute here in Madison. And so it's really important to remember that clinical care accounts for only, we believe, 20% of health outcomes. And as I'm circling this in bold red in part because within that, it includes access to care. So many people think, well, if you just had everyone have health insurance and access to healthcare, we'd be fine. But actually that is only accounts for that 20% of health outcomes. So when you look at it, it's really socioeconomic factors and the physical environment that's really undergirding what is driving health outcomes. And you could argue that those health behaviors that are thought to make up about 30% of outcomes are also driven by those socioeconomic factors as well as the physical environment. So just a reminder that social determinants of health are defined as conditions in our environment in which people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and the quality of life outcomes and risks. And I asked this question when I gave a talk in April around COVID-19 and health disparities, which is what is the strongest social determinant of health driving inequities? And I'm asking, does anyone remember what that is? Or if any of the first year residents, I don't know if you're able to unmute yourself
It's zip code, isn't it?
You could think about zip code. So it's a, and that came up last time too. It's a little bit more specific than zip code. Because it won't really work if you're renting necessarily in a certain zip code. So it's basically, so it's really wealth. And this great illustration from the Occupy movement, and it really gets at how wealth is distributed across the United States. 40% of the country owns that little dot in Texas, right? So this is from the Brookings Institute. There's significant disparities in wealth. So this is net worth. So this is your assets minus your debt. So you can see that African Americans or Blacks are at the bottom with Hispanics. And so what is really driving wealth? This is a really important slide from the Century Foundation. It's really home ownership. And so, yes, it is zip code that's driving things, but it's really, do you own something in that zip code, which really is driving wealth disparities. And this is really interesting to look at because we put such emphasis upon education. Education actually will only still account for a fraction of what's driving, and income is still less than home ownership in terms of what drives wealth. And so from some data from 2016, there is a 10 times difference in net worth between white families and African American families. This gets back at education again, which is, again, really interesting to see that if you are white without a bachelor's degree, you likely still have greater wealth than if you're an African American or a Latino who has a bachelor degree or higher. And even that other category, that would probably include yellow people like me, so Asians, still, even with great education, usually still have less wealth than their white counterparts. And this is really where it gets to. You really have to understand your history, basically. And this is probably not something that we were taught, certainly I was taught when I was growing up in history classes, but it's really housing discrimination that is what is driving a lot of these disparities in wealth. I need to sort of thank Sherry Johnson for this slide. So Sherry Johnson is the director of the Population Health Institute currently, and she and I both gave a talk together last week to the medical students. So this is showing as an example, so issues around redlining that you have heard about, or racial covenants, this was all happening around the 1930s. And so if you were unable to afford or obtain, it's not even affording, but if you legally are being, and there are policies in place so that you cannot buy a home, you may end up in urban rental housing in the Bronx of New York City, or public housing. So you don't actually own a home, while there may be a white young family who's able to buy a suburban home in Levittown, New York. So Levittown is 25 miles from Manhattan. It's on Long Island. And they bought that in 1947 for $8,000. Today, that cute little house is worth over $500,000. And so you can see how wealth accumulates over time for families, but and how other families will not have that accumulated wealth. And this slide also from Sherry Johnson. Again, this is from rankings, looks at home ownership in Wisconsin. Actually, Wisconsin does fairly well compared to the rest of the nation. But again, it's really white people who are doing fairly well. And it's remarkable to see how low African Americans are in terms of home ownership. You can also see Hispanics are down there. That's American Indians and Asians. Everyone is way below the national average home ownership in the state of Wisconsin. And then if you were reading the New York Times just last week, this came out looking at how what has turned into racial segregation of neighborhoods due to issues such as redlining is now looking at how it's affecting where are in our communities, in our towns, are the hottest places to live. And it looks like it's all along racial lines. So you can see that sort of in this picture, and you can look up this article on August 24th. And so just by having a single degree increase in temperature can account for a heightened risk of dying of 2.5%. I want to sort of remind folks or introduce folks, if you aren't aware, to the Race to Equity report. So this was published in October of 2013 by the Wisconsin Council on Children and Families. This report focused specifically on African Americans, so this does not include Latinos or American Indians, for example. But what they were able to show were these most astonishing results, which include the following as an example. So this was looking at various social indicators, and so they were looking at poverty amongst children. And at the time of the report, Dane County had the widest Black-white poverty gap in the United States of America. So it was not in Milwaukee, it was not in Chicago, it was right here in Dane County. There were all this disturbing data coming out from that report around incarceration rates. So here you again can see that Dane County, we were arresting Black youth at 6 times the rate of the state and 3 times that of the nation. And this is a very important statistic. This is around 3rd grade literacy rates. Again, we had the widest gap in the United States of America for 3rd grade literacy between Blacks and whites, and it was right here in Dane County. Literacy is highly related to life expectancy. So this is a really important social determinant to think about. And then by April of 2014, the Annie E. Casey Foundation released another report called The Race for Results. And this looked across our entire state. And again, it found that the worst state for a child to live in, if one was African American, was actually not Mississippi, not West Virginia. It was here in the state of Wisconsin. Notably, Asians also out in the state of Wisconsin, and we're probably talking mainly about our Hmong population. We are the state with the 3rd largest Hmong population in the United States. This was published, by the way, internationally. So my brother was reading about this in California. And then this continues. So, here's our coming from Milwaukee in this journal. This is from 2016. And then last year, again, reporting that Wisconsin had the widest achievement gap in the United States, according to the nation's report card. And I'm taking a slide from the wonderful Dr. James Ersink he gave a great talk yesterday about homelessness. And I was quite struck by this slide. So this is looking at homelessness in Dane County. This report is from 2019. And when they did a count of 560 plus individuals, remarkably 53% of those who were not sheltered were African American. You should know African Americans make up about 5.5% of the population in Dane County. And again, this is showing another, it's called the Racial Index to Black. Again, Wisconsin is at the top of the pile. A lot of this is in part because white people, including white children, actually do very well compared to the rest of the nation. So what we're showing you is that Wisconsin, Dane County, unfortunately, is doing a very good job about leaving certain groups of people behind based on race and ethnicity. So a conclusion from the Annie E. Casey Foundation was the following. For African American children, the situation is dire. In general, states in the Rust Belt and Mississippi Delta are places where opportunity for Black children is poorest. African American kids face the greatest barriers to success in Michigan, Mississippi, and Wisconsin. And so again, as I said before, social determinants are stronger predictors for health outcomes than health access. So wanted to share this. In Dane County, so think about this, in 2012, African Americans were more likely to have health insurance and to receive adequate prenatal care. This was compared to their Black peers nationally. Despite that, we have this. So we actually have the worst infant mortality rates in the United States of America, actually is right here in the state of Wisconsin. And then this came out in Health Affairs in 2014. Fortunately, the life expectancy gap between Blacks and whites has been shrinking across the United States for the past couple of decades. The one exception to that was in the state of Wisconsin, and that gap was widening between African American and white women. And this was a slide I showed back when we were talking about COVID-19 back in April, but just wanted to show it again because it's so startling. So again, the CDC was not even reporting back then about racial and ethnic health disparities for COVID-19, and Milwaukee was the first place doing this. And so even though African Americans were making up or do make up only 26% of the Milwaukee County population, we are finding that at least as of April 3rd, 50% of the folks who were testing positive in Milwaukee County at that time were African American, and 81% of the deaths that had occurred at that point were African American. And then here's an interesting note on poverty in Dane County specifically. So teenage birth rates for African Americans in our county are slightly lower than the rates for African American teens in Wisconsin and the nation. So we actually are doing pretty well for that. And furthermore, the percent of African American moms in Dane County who have at least a high school diploma is higher, again, than the state and the nation. Now, usually a lower teen birth rate and a higher maternal education are protective factors that help deter high rates of child poverty. But it's interesting because this is not the case in Dane County. So here is another conclusion. This is from the Wisconsin Council on Children and Families, the Race to Equity report. They say the following: the alarming truth is that our numbers taken as a whole suggest that the distance between whites and Blacks in terms of well-being, status, and outcomes is as wide or wider in Dane County than in any jurisdiction, urban or rural, north or south, for which we have seen comparable statistics. The one inescapable and pivotal finding that arises from all the numbers we have collected is the extraordinary degree to which poverty and disadvantage in Dane County have become correlated with color, or to put it even more in more stark terms, the extent to which economic deprivation has become profoundly racialized. So conscious racism and color prejudice may not have been the primary cause of this extreme racialization of disadvantage, but allowing such a close link between color and disadvantage to persist can only serve to nurture stereotypes, foster profiling, and produce differential expectations for achievement within the community at large, while at the same time undermining motivation, aspiration, self-esteem, confidence, and hope among African American children and their families. So I wanted actually to share with you a quick YouTube video that I'm going to have Matt, I'm going to stop sharing my screen here. And this is about what's called the cumulative, the life effects of the social construct of race.
The story of Kim Anderson, a successful Atlanta executive and lawyer, illustrates exactly what David and Collins are talking about. We know that a healthy lifestyle should lead to a healthy baby. Women who eat well, exercise, get prenatal care, avoid alcohol and drugs and cigarettes, are more likely to have a good pregnancy. But one of the best predictors for a healthy pregnancy outcome is higher education.
This is a picture of me, May 1984, when I graduated from Columbia Law School. People would think I'm living the American dream. A lawyer with 2 cars, 2.5 kids, the dog, the porch. A good husband, great family. I've always been lucky to have good health. Always ate well, exercised, never smoked.
So when we look at Kim Anderson, a well-paid lawyer in good health, we would expect her newborn to be a healthy, full-term baby. It didn't turn out that way. Back in 1990, when she was pregnant with her first child, Kim went into labor 2.5 months early.
I just wanted to know at least that if she was born alive, that at least we had a fighting chance. But I heard her cry, I said, thank God. But she was so small. I mean, you could like hold her in the palm of your hand.
Kim's baby, Danielle, weighed only 2 pounds, 13 ounces when she was born. She joined the ranks of almost 300,000 low birth weight infants born in the U.S. that year. About 1 out of every 14 babies, all of them at a high risk of dying before their first birthday.
I remember getting home and being in the bathroom, I fell apart. You know, because it's like I didn't get to take my baby home, you know. I remember just sort of falling apart.
In the terminology of social scientists, Kim Anderson's family enjoys high socioeconomic status, which increases the odds for overall good health.
Persons who are higher in socioeconomic status, persons who have more income or more education or better jobs or more wealth, live longer and have fewer health problems than those who are lower in socioeconomic status.
Education, for example, predicts infant mortality for both Black women and white women. And the more educated you are, the less likely you are to have a low birth weight baby, a preterm baby, or an infant death.
Women who are poorest and least educated are those whose babies are at greatest risk in any racial group. But the babies of African American mothers with higher education are still at greater risk than we'd expect. Infant mortality among white American women with a college degree or higher is about 4 deaths per 1,000 births. But among African American women with the same level of education, infant mortality is about 10 per 1,000 births, almost 3 times higher. In fact, African American mothers with a college degree have worse birth outcomes than white mothers without a high school education.
Think about this. We're talking about African-American doctors, lawyers, and business executives, and they still have a higher infant mortality rate than non-Hispanic white women who never went to high school in the first place.
As a mother, you're thinking, I did all the right things. They told me to take vitamins, I took vitamins. They told me to walk, they told me to eat vegetables, they told me not to drink, I didn't do all that. And why is my kid sitting there with these needles? And, you know, so you feel real helpless. You really feel helpless.
So doctors Collins and David asked themselves if the answer could possibly be genetic. It's well known that prematurity can run in families. Is there something in the DNA of African American women that tends toward premature births regardless of education, prenatal care, or lifestyle? To answer the question, they created a study based on a simple assumption.
If there was such a thing as a prematurity gene and it came from Africa, then Africans should have more of it.
They compared newborns among 3 groups: African American women, African immigrants to the U.S., and U.S.-born white women.
It turns out that the Africans and the whites were about the same. The African Americans, on the other hand, had babies that weighed almost 8 or 9 ounces less than the other 2 groups.
In other words, African immigrants to the U.S. and white women born in the U.S. had similar pregnancy outcomes. So if there is any genetic predisposition for low birth weight babies, it's doubtful that it falls along what we call racial lines.
She hadn't had a drop in her heart rate for those.
It turns out that when African women immigrate to the U.S., it takes only 1 generation before their daughters are at risk of having premature babies at a significantly higher rate and with poorer birth outcomes.
Has your heart rate been in that range for 180?
No, actually, it's been about 160.
So within one generation, women of African descent are doing poorly. This, to us, really suggests that something is driving this that's related to the social milieu that African American women live in throughout their entire life.
Great. Thanks, Matt. Appreciate that. Okay, so again, so the term that has been used is the cumulative life course effects of the social construct of race, which to me is a mouthful. And so the way I've interpreted this is really an argument for the cumulative effects of racism. And so you should all know that the Dane County Health Council is working closely with the Foundation for Black Women's Wellness. And so the Foundation for Black Women's Wellness, along with Equity by Design, actually did a listening session to really explore the priority concern by the Dane County Health Council of low birth weight disparities between African American and white women. And so they interviewed some 300 African Americans, men, women, and youth around Dane County. And these were the themes that emerged. So I'll just read them quickly to you. So at the top is racism, discrimination, and institutional bias. They talked about bias and cultural disconnect in healthcare delivery experiences, economic insecurity, housing insecurity, poor access to health supporting assets, inadequate social supports, gaps in health literacy, education, and support, disconnected and hard to navigate community resources, systemic barriers to individual and family advancement, and chronic stress. So can we move beyond disparities and race? So one thing that the first year residents and I were discussing back in July when they first got here was thinking about maybe using the term not just health disparities, but health inequities. And here's one definition again, that when disparities are strongly and systematically associated with certain social group characteristics, such as level of wealth or education, whether one lives in a city or rural area, I'll add whether one is Black or white, they are termed inequities. And what drives these? Well, these would be differences in quality of care, differences in access to care, but also very much so differences in life opportunities, exposures, and stresses that result in differences in underlying health status. And just to clarify, and this is, again, thanks to Shelley Shaw this time for helping me think about this, wanted to give you some different definitions for discrimination versus racism. So discrimination, you could say, is an action based on one's prejudice or one's bias. Racism is when you take prejudice or discrimination and you add that with systemic power or systemic power. So, in fact, needless to say, any one of us listening to this could experience a discrimination or bias, and this could include being a white man. You can experience this, but you could not talk about something, that you might have heard this term reverse racism or reverse sexism. So only minority communities can actually experience racism and sexism. So really, when you think about the isms and you're adding the power dynamic where you have real outcomes, right? African Americans definitely have different outcomes when they are confronted with the police than if you're white. So that is an example of systemic racism. You can't have reverse racism. Kamara Jones writes really beautifully about racism, and so here is what she would say. She would define it as a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which is what we call race. And this system unfairly disadvantages some individuals and communities. It unfairly advantages other individuals and communities, and ultimately it saps the strength of the whole system or the whole society through the waste of human resources. And she describes 3 types of racism. And so the first is personally mediated racism, and this is maybe what we oftentimes think of. So this is prejudice and discrimination by individuals toward others. We're all now learning more about institutionalized racism. So this is differential access to the goods, services, and opportunities of society simply based on race. And then I'll also mention that she describes something called internalized racism. So this is acceptance by members of a stigmatized race of negative messaging about their own ability and intrinsic worth. So what can we do? So first of all, we really want to be really thinking about what we can do to move toward health equity or to equity. And so just to say, there is a difference between equality and equity. Equality is a very American notion, and it's really about trying to give everybody the same thing. But this doesn't really work if we all are not starting from the same place. So equity, again, is really about giving people access to the same opportunities. And then if we can assure equity, then you can enjoy equality. And this is a slide actually from Dr. Joff Swain, who gave this to me. And to be honest, you know, I think that reality on the end is important to think about. That may be the land that we're living in today, where we're actually kind of digging people into holes. So let's start with personally mediated racism. So what could we do here? So first, I would argue that we need to move beyond cultural competency. So cultural competency is this idea of identifying, you know, cross-cultural expressions of illness and health, and you know, counteracting the marginalization of patients by race, ethnicity, and other identities, and then developing strategies around communication and diagnosis that is culturally specific. So, you know, without question, it's very important for example, say our Hmong population, that we have a good understanding of how that particular population may approach death, for example. But structural competency is really an idea of really understanding that it is various systemic structures that are shaping clinical interactions, and takes cultural competency to a different level where we're developing extra clinical language around structure, re-articulating cultural formulations in structural terms, imagining structural interventions, and developing even structural humility beyond cultural humility. So as an example, you could even sort of think about myself. So as I am of genetic ancestry, I'm 100% Korean, but I'm also a first-generation American. So my parents immigrated here, and I grew up not in a Korean American community, but in a rural community in America. There were no other Korean Americans around, let alone, there were hardly any other people of color around. So would you necessarily treat me like a Korean? Probably not. Would you treat me as someone who was white? You know, perhaps you should think about some other things there too. So you sort of start to see that one has to have a really deep understanding of politics, of history, as well as culture, to really understand how to care for individuals, and how to, in our case, talk about move toward anti-racism. And then Kamara Jones also talks about thinking, challenging us to think even more intentionally about social determinants of health. So oftentimes we think about social determinants of health and we think about transportation, food, housing. Those are all very important things to think about, but then there are the isms. So she also thinks we should think about the social determinants of equity. So in this case, you would think about systems of power that determine how socially defined populations are distributed in certain social contexts. So if you are addressing social determinants of equity, we need to be monitoring for inequities in exposure and opportunities, as well as simply disparity outcomes. We would be examining structures, policies, practices, norms, and values. and we would be intervening on societal structures and attention to systems of power. So it really challenges us to think about social determinants of health in an even more, frankly, complicated way. This picture actually comes from Australia. So the Australians are really trying to think about racism in the context of their Aboriginal population, but I just kind of love this poster. So racism makes me sick. So going back to that report called Unequal Treatment, this was another conclusion that they made. They said, although myriad sources contribute to these inequities, some evidence suggests that bias, prejudice, and stereotyping on the part of healthcare providers may contribute to the differences in care, often despite the provider's best intentions. So, think about really active listening, intentional communication. This is something for you residents, is an ongoing, this is what you're learning for the next 3 years. But know that studies show repetitively that people of color oftentimes will report they have a more difficult time communicating with their physicians. And, there is implicit bias. So there's been a lot of conversation around this this summer. And just so you know, I actually give a whole nother workshop around implicit bias. So for the residents, we'll be doing this in several months. But I wanted to at least give you a glimpse about implicit bias. So these are these biases that we have that we may not be fully conscious of. And this is this great slide that I'm borrowing from Tillman Farley, actually, who came in, was our Farley Prize speaker back in 2014. So in this study, they actually were able to look at and measure the explicit and the implicit bias of a group of clinicians, and then asked their patients what they thought of their physicians. And basically, if the clinician had low explicit and implicit bias, needless to say, their patients loved them. They thought that was great. But what was really interesting about this study is that if the clinician had relatively high explicit bias, then actually, although that wasn't a fabulous thing, patients could deal with that. What patients could not stand were those clinicians who had low explicit bias, meaning that they would not overtly say that they had any particular racial preference for a particular group, for example, but they had very high implicit bias. So they were not conscious of their biases that they had. Patients couldn't stand that. So patients, actually, you should know, can pick up on our implicit biases very easily. So there is something called Project Implicit that you can just Google. And again, with the first year residents, we'll be doing this later in the year. But if you haven't had done an implicit association test, I really encourage you to do one as a way to start to do your own self-exploration of your own implicit bias. And if you have done it in the past, it's kind of fascinating to do it again, actually. So there's that. So now let's move toward institutionalized racism. So this was a study that was in that unequal treatment report. So this is back from 1997, and they found that African Americans at that time were 32% less likely to undergo bypass surgery and 13% less likely to undergo angioplasty than whites for heart disease. And so, but this has been changing. So here's an example of when, in this case, researchers put together studies with a very intentional design where they were looking at racial and ethnic disparities and looking at putting together processes that were non-racist into institutional practices and policies. That this particular number around the time from getting to the ER door into the cath lab, that has been improving across the United States over the past decade, but it's not only improving for white people, it's actually improving for Black people, and that disparity gap is actually shrinking. And so how did they do that? Well, I think that they thought about things from an equity standpoint. And so, again, the first year residence I back in July had an opportunity to think about application of an equity lens. So I just remind you of this. And for those of you who are interested in this comes out of Multnomah County, where Portland, Oregon is. And it's simply a very structured tool. It's like a checklist of how, if you're doing a QI intervention at your clinic, you could really think intentionally of, by doing this intervention, for example, to improve hypertension, am I going to be improving hypertension for maybe a group of people, or will I really be able to improve hypertension for everybody? I think sometimes we do QI projects, again, with the best of intentions, but we actually probably widen disparity gaps. And then this actual link, which I'm happy to share with you offline, will give you to more access as to how to use this particular equity empowerment lens model. And then let's move toward internalized racism. Like, what could we do about that? And so actually a group of us here in our department, along with some wonderful medical students, did a qualitative study and where we had a chance to do some focus group sessions with undergraduate students here in Madison, and asked their experiences as they hoped to enter a future health professional career. And it's pretty astonishing what these young people who are only 18, 19, 20 years old have already experienced in their lifetime, in terms of comments such as, well, you got, and this is my friend who said this, you got into the University of Wisconsin-Madison because you're Black. Right? So this kind of feedback that these young people are getting, not only from their peers, they're getting this from their counselors, they're getting it from, their parents in some instances. This is what drives issues of internalized racism. So there's something called stereotype threat, which is when you actually remind someone of their identity status, they will perform differently. So the classic study that Claude Steele did, who coined the term stereo threat, was he started giving math tests to middle schoolers, and you take the math test, but in another cohort, they would ask for demographic data prior to the math test. And so you would check if you're a girl or a boy, and you would check, what your race is. And then you're sort of reminded, oh yes, I'm a girl. Or you're reminded that you're African American. And interestingly, you perform worse when you're reminded of this stereotype that girls don't do as well as boys in math. So this can really affect outcomes. So there are ways we could reduce stereotype threat, simply by even starting by acknowledging that complex systemic and systematic challenges that people of color face. So race really does matter. It's really important that we find opportunities to, of course, diversify our department, be they clinicians, staff as well. And, and this is part of the reason why my talk is beyond disparities in race. There is a group of we educators nationally who had a sort of a pact that we would no longer talk about health disparities anymore. We would talk about health equity. We were going to name racism. And so this is one way to reduce stereotype threat. For those of you in your clinics, you could even just walk into your waiting room. What do the magazines look like? What's on your walls? And are those things that can be triggering to certain groups? And then I just wanted to share this, again, going back to the fact that there is a real economic argument to be made. This, again, Tillman Farley shared this with us when he returned to our department recently and gave a talk. But this article comes out from Virginia Commonwealth, and they looked at what would happen if you eliminated health disparities. And they found, using kind of big data analysis, that by eliminating health disparities for African Americans, 5 deaths could have been averted for every life saved by medical advances. It is worth working on health inequities. Ultimately, we want to move toward liberation. Can we take away the fence? And I will say very briefly that the Diversity, Equity, and Inclusion Committee has a proposal out on thinking of a really long-term strategy to help our department become an anti-racist department. This is a long road, but if you go to our public-facing departmental website, there's a diversity tab, and you can see under anti-racism initiative some of what's in our proposal. And we will have opportunities to discuss this further with folks. So we'll be presenting to the FPM meeting at the end of this month, as well as to Alumni Hall. I think that's September 14th. And we will be working, we are hoping to be working with the NINA Collective. So this is a group of consultants made up of all these wonderful women, basically. It's a multicultural group who have expertise in leading anti-racism work. So this is kind of what they'll be working with us toward, hopefully in the next few months. So they'll help us with visioning our strategy and relationship building. They're going to help us look at the survey that I hope many of you have completed. We're going to provide training and capacity building across our department. We're going to also be launching racial affinity caucus groups, and then ongoing action planning and evaluation. Of note, UW Health is also trying to do this as well. And so again, for those of you in our clinical system, I again remind you that we have these amazing employee resource groups that are really worth looking into, and I'd be happy to talk with anyone about that if you do not know what I'm talking about. And then I'll just show here as well, there's so much learning that we all need to do, but here are just some other classic short videos that I sort of proffer up to you if you would like to do some more learning around this. And with the residents, we're going to be watching Dorothy Roberts this afternoon about the problem with race-based medicine. So I'm going to stop here. And happy to take any questions. Yes, and then Val actually shared an article that was just published also within the past 2 weeks about another study showing that newborns are less likely to die when cared for by African American. So Black newborns are less likely to die when cared for by Black physicians. And that's the land that we're living in right now. So it's not that we really want to promote, segregation like this, but that is what the studies are showing. So thank you, Val. And that comes out of BMJ. And then Michelle is asking, are there sub-work groups working on these types of concerns? Would be nice to have work happening in clinics, for example. That is exactly what we're hoping to do we'll be sharing that there's going to be, you're even using the right language, we're calling them work groups, and would love to have folks in the clinical environment participate as well if you have time. And we will be sharing more about that soon. I could see here. And I'm sorry, so I'm not looking at my chat. So if there are other questions, someone will have to read them to me. I'm just going to show you what these work groups are.
Jennifer, the question in the chat is it best to tackle the issues you discussed at more of a clinical or public health level? Where has it been shown to be most effective to address these issues? Schools, health departments, clinics, etc.
Well, I mean, obviously what we're doing now, although there's lots of attempts at working at this in lots of different levels, I think I think we need a multi-prong approach, if I'm honest about this. I mean, this is a huge societal problem that we're battling with right now. And so that's in part the Diversity, Equity, Inclusion Committee at within our department is really thinking about not just focusing, for example, on only the residents or, only staff. We're really trying to think broadly across our whole department. But I think we should be trying to align ourselves with larger in our health system. So that would be the UW Health side with our academic community. So what is going on not only at MPH, but on UW campus. And then, as I hear your voice, Shelley, there are opportunities to collaborate closely with, be it public health, Madison-Dane County, or even, as we collaborate closely with our peers up at the Population Health Institute, they are further working across on the state level, right? So Wisconsin Public Health Association, remember, had their anti-racism resolution that came out of Wisconsin Public Health Association. So these are all partners that would be great to work strategically together with. So again, going back to these work groups, you'll see again, and you all can just Google this and you can get access to this. So we are looking at working groups. And if you go to this PDF that Maddie Batsley kind of put here, you'll see that our hope is there are lots of opportunities to participate. So we are literally just at the sort of infancy stage of launching this, but if you are interested in participating in a work group, if you wanted to contact myself or someone on the DEI committee, we would be happy to find a working group home for you. So just wanted to let you know, we'll be talking more about this in the near future. So again, myself and certainly others with the Diversity, Equity, Inclusion Committee would be happy to answer any other questions people have. So feel free to email any one of us and we'll do our best. But thank you all for joining during your lunch hour. So thanks.